Hello, my name's Susie Wilson. I'm the Artistic Director of Claude Ensemble and lead the Performing Medicine programme. And I'm also an honorary professor at Barts and the London School of Medicine, which is part of Queen Mary University of London. And I'm sorry I can't be with you all today and we can't all be together in a room for this conference. So I'm recording this from my flat in London. Performing Medicine has been working, providing arts-based learning courses in medical schools and NHS trusts for about 15 years. We work in lots of different places. The medical schools that we work with include Barts and the London and the School of Medical Education at King's College. We also work in NHS trusts such as Guy's and St Thomas's in London, Barts, NHS Trust and Swansea Bay. And we often do consultancy work with medical and nursing schools about how we can help to embed arts-based learning in their curriculum. At Barts and the London, our sessions are part of the core curriculum and they're systematically embedded across all 5 years of the medical school, and they're compulsory for students. We appreciate that this isn't generally the case. There are examples of places where there's a medical humanities or arts element embedded, but in the main, in my experience, arts in healthcare education are mostly small, one-off optional projects. Often they're things called selected study modules, which students can choose to do. So on Alex's request today, I've been working with my colleague at Performing Medicine, Bella Ecott, and we have identified 7 challenges to a more sustained integration of arts in healthcare education. And we've offered some solutions that we've found over the years to overcome these challenges. So, challenge 1 is the lack of understanding across the arts and health sectors. So it seems to me that it's hard to sustainably integrate arts-based approaches in health education if arts people and healthcare professionals and clinical educators don't understand each other's worlds very well. So on the one hand, there can be a lack of understanding about what the participatory arts actually are and what they can offer. And on the other hand, there's a lack of understanding among artists about the realities and challenges of working in the healthcare sector. Perhaps this is related to a broader gap in understanding between arts and sciences generally. Our solution to this is within the healthcare settings and education settings that we work. We don't really lead with the arts. We find out what are the needs of the hospital or the medical school students. Or we look at what are the guidelines of the General Medical Council and what skills the students need to develop. We explain when we're working with people that instead of this being about the arts are simply a methodology for learning, and that we map our approach onto their needs. So often we talk about practical skills, developing tangible practical skills that are relevant to their clinical practice. And to describe this, we draw on a model that we've designed called Circle of Care, which shows how arts-based approaches can support the development of skills that are necessary for healthcare practice. There are times when we do lead with the arts. For example, at the moment, there's a lot of interest in work around social prescribing, and the GMC have said that medical students need to understand what that is, and clearly culture and the arts have a big role to play there. The second challenge is about language. So between the arts and the health sectors, the words that we use can have very different meanings for different things. So an example I often use is about energy, the word energy. So if you're in a drama or an arts class, people often talk about energy. In a medical school or a healthcare setting, that can sound quite kind of hippie. The same as if you're doing a physical warm-up. If you start using too much flowery and decorative language, it can really alienate people. And it's also very easy for things to get lost in translation. And when this happens, the kind of core purpose, if you like, of the work that you're doing doesn't land as it was intended. So a solution to this is that we pay a lot of attention about how we frame courses and the language that we're using when we're running them. And again, the circle of care model that I've mentioned is very useful for that. We try to use straightforward, stripped back language, both in our sessions and also when we're describing our work to the commissioners, the people who might commission our work. When we train our associate artists, we also make this really clear. The third challenge is about institutional structures that we're working within. For anyone working in healthcare or medical education, it's often very hard to make space in what are very packed timetables for students, or to get staff to be released for training or courses when they have very little availability. Even for mandatory courses, it's difficult for them to take a day off to be released. We've found the solution to this is aligned to the first challenge that we were talking about, that we really lead with the needs of the people that we're working with. How does our work align with the needs of the students' curricula, or with hospital policies, or with the guidance from the General Medical Council, so that it becomes really clear that it's beneficial for them to make space to work with us. It helps when we collaborate on developing courses that already exist in the curriculum, as well as us developing new ones. The next challenge is about expertise and how we value it. So sometimes when we're working in in a healthcare setting, and a course goes really, really well, after it's been delivered once or twice, it can be assumed that someone in the medical school or the hospital, a clinician or a clinical educator, can then take over the teaching of that workshop or course. I've often been asked by clinicians, can you do a few sessions with us so that then we can teach ourselves? And this is a really complicated and sensitive area, because that's often the model that works in the NHS. However, the artist who might have been delivering that course has built up their experience, perhaps over a 20-year career, even though they make it look effortless. So one thing that we kind of say to people is that if an artist suggested that they could be taught how to operate in an afternoon, they wouldn't be taken seriously. So there's something about kind of respecting different expertise. Also, to suggest that this kind of work should be taught by medical educators is missing one of the key benefits of artists working in health education, that by working with outsiders, if you like, it encourages an outward-looking medical profession that values different perspectives. There's a real risk that the quality of the work is diminished if it's not led by artists. And if arts are to be integrated in health education, we need artists involved in the delivery. So another solution is to really communicate and celebrate the particular skills and expertise of our artists. We're really clear that the training the trainer model isn't appropriate in many cases. But having said this, we do work hard to develop simple structures and exercises that can be used by staff after we leave. It's also useful to explain the next point, which is challenge 5, which is about ways of learning. With arts-based teaching approaches, it's not just what you learn, but how you learn it. The form of the session is part of the learning, as well as the content. They are the same thing. It might be that we're moving around a room, there's a lot of group discussion, and this is absolutely part of developing the skills. And this is a point that's really easy to get lost, and it's often hard to articulate when people haven't experienced it. And this leads on to a very practical point about the kind of rooms that we need when we're teaching. We need a big room to move around in, which is very different to a lecture theatre or to the kind of classes that most medical students use. Also, there's an issue about online learning, especially right now. And there's a challenge in articulating why being in the room is so important for our work, and to make sure that contact with students and that space with students is valued. A solution to this is to try to encourage as many people to get the actual experience of activities and exercises, especially people who are programming them. So to ask the Dean of Medical Education to come to a class, or people who are commissioning the courses. When we do conferences, we often do small taster sessions, which immediately convey how these approaches work. And often people who have experienced the sessions then become our biggest advocates. Challenge 6 is about how healthcare, how higher education institutions and NHS institutions work with external organisations, particularly arts organisations in our case, and how we work together within very specific administrative, financial and bureaucratic procedures. So things like procurement, for example, can be a real problem when you're working within an NHS trust. I think often within the NHS, there's a different kind of understanding of things like, how different images should be credited, and also how the economies of the arts and health sectors are so different. How small arts organisations don't have the same kind of cash flow that NHS Trust has. And also contracts, ideas around intellectual property, all of these things can be quite kind of challenging to work out. I think also the economy, the difference in economy between pay and salaries for healthcare workers and freelance artists are very different. So all of that working out can be a challenge when you're wanting to partner with universities or with NHS trusts. Our solution to this is to be as clear as possible from the start with our contracts, and that has, when we're still learning, even kind of 15 years in. I think it's important to anticipate these challenges and to name them. And really importantly, for us as an arts organisation, we need to keep advocating for artists and good pay for artists. We are building resources all the time so that the people we work with can administrate everything kind of much quicker and simpler, and kind of creating an architecture which makes it easy for people to work with us. Yes, I think there's a different understanding of what collaboration means in different sectors. And I think some arts organisations are very good at that. And some health places and care places are very good at that too. But again, back to this idea of language, it's really good to make the time to talk through some of this so that problems don't occur later down the line. The next challenge number 7, is around workforce development. As this field of work is developing, there's more demand, there's a growing interest in social prescribing. There's a new National Academy of Social Prescribing, and there's a real debate about the role that arts and culture has to play in this. The more this all develops and grows, the more artists need to be skilled up to work in healthcare education settings and also in social care settings. And as I've outlined already, it's really crucial that artists working in this field are sensitive to and knowledgeable about the realities of working within these systems, and that people working in health also understand the realities of being an arts organisation or of working in the arts. Our solution to this, we're working towards developing this artistic workforce, and we're collaborating with a variety of arts organisation and education institutions across the country. The situation with coronavirus that we find ourselves in today, I think, presents a radical moment to reimagine our health and social care systems, and for arts and culture to be at the heart of this new vision. The creative responses of artists and community groups, health services and volunteers all around us right now demonstrate the way that culture and arts can meet health and social care in really very inspiring and very effective and very skillful ways. And I really hope that we can build on this and take this opportunity to work together in the days and years to come. Thanks very much for listening today. Thanks to Alex for organising the conference and to getting it online so quickly. If you want to follow what we're doing, you can go to the Performing Medicine website, performingmedicine.com, or follow us on Twitter. And I look forward to seeing you in a room sometime before too long. Thanks very much. Take care. Bye.